this, I would first like to now go to the first speaker. So let me quickly introduce our first speaker. You all know him very well. So Dr. Saiful. So Dr. Saiful, he has graduated from the National University of Ireland with multiple honors and gold medal winner of the anatomy. And he has become a consultant in endocrinology and diabetes since 2008, over 22 years of his clinical experience of working in UK as well as in Malaysia. He was the head of the department while working in the Northern University of UK. He was a senior clinical lecturer at the Queen's Belfast University at the UK. He was also awarded with a fellowship of the Royal College of Physicians of the UK. And he has been very passionately following this diabetes as well as in obesity and other endocrine disorders like pituitary disorder, thyroid disorders, and so on. So with this short introduction, I would now like to pass it on to Dr. Saiful to start today's the first talk. The first talk is on selecting right patients for Saxenda. So with this, I'd like to now pass it on to Dr. Saiful for the presentation.
Okay, thank you very much for the very, very kind introduction, Sid, and good morning to you all on this Sunday morning. Let me just go back to the start. Yeah. So today, I think it's a very important topic that we're facing in Malaysia, obesity, and talking about it as the most common nutritional problem that we're facing. I call it the twin peaks of diabetes and obesity is what I face a lot in my clinic. But I'm going to talk about how obesity contributes to a host of other diseases, which leads to hypertension, diabetes or prediabetes, dyslipidemia associated with PCOS, osteoarthritis. There's so many complications that can occur from this. But the problem that we always have is that I think we don't really know when it comes to patient management. There's so many barriers for getting to know the patients, getting time to talk to the patients, what's their life like, what's their diet like, and sometimes we don't have time to even routinely review the medications that they're on that sometimes have adverse effects of weight gain, and having the time to actually talk to them about medications that can aid weight loss, to reduce their risk of pre-diabetes or the risk of hypertension, dyslipidemia getting worse. To me, I think diagnosing obesity is not really a clinical challenge. The challenge for us is the strategy of bringing up a topic which doesn't harm the doctor-patient relationship, but yet, we get on their side and we can identify areas where they can, and hopefully we'll be able to make not just lifestyle changes, dietary changes, weight loss goals, but also supporting them with success. And this is the hard word, the success of the medications or procedural treatments that we give to our patients. And I'm talking about today, we'll be talking about Saxenda per se, and where this particular medication plays a role. These are my, this is the content in which we're going to talk about. I'm going to talk about a few cases here. What are the right patients that we need to think about that we can use this medication in? I think it's important to bear in mind that lifestyle choices as well can predispose to diabetes and hyperlipidemia and hypertension, PCOS. I had a patient yesterday who had a BMI of 50 and HbA1c of more than 10.7%, has had PCOS since he was 11, irregular periods from the very beginning, and a bit of hirsutism and acne, and had problems with, and she's 31, she had problems, unfortunately, with infertility now. So there's so many things that we see in our practice that we need to target per se. So starting off today, apologies. This is probably what some of us have had this morning, I'm sure. I'm not going to lie to you all. I went for a walk early this morning, and unfortunately, the first thing I had after the walk was I wouldn't say I had this nasi lemak, but I would say that I had a bit of a thosai this morning, which obviously is not that good if you think about it. But having this results in huge amount of 730 calories, including the nasi lemak that we would have as well, along with it. And the trends of obesity, sorry, the slides are going forward a bit too quick. I think it's important to bear in mind when we talk about obesity, there are certain issues that we're facing here in Malaysia. 1 in 2 adults of us here in Malaysia are obese, which is quite scary, to be frank. And 1 in 2 have abdominal obesity, which I think is a little bit concerning. Obesity is a very complex, sorry, it keeps going forward, multifactorial disease. And it's something that we have to bear in mind, that in addition to what I would call digesting nutrients that we take in, the intestines that we have, and all the visceral organs, the pancreas, play a very, very important role in sensing and certain signaling as well, in what I would call this energy homeostasis. The gut, which is probably the largest endocrine organ, the pancreatic beta cells, and there are some elements as well in the portal hepatic circulation, and more importantly, the adipose tissue or the fat tissue. All of these communicate amongst each other with certain controllers in our hypothalamus, and then the multiple sort of, I would call, neuroendocrine pathways. And all these signals per se, they kind of reflect not just energy stores, but nutritional state, and there are other important parameters as well. And they're all integrated together in the hypothalamus. I'm going to explain further about that. And they coordinate this energy intake that comes in and energy expenditure. And I think our understanding of all these different, what I would call regulatory circuits, neuroendocrine circuits, and signaling molecules help to allow us to I would say that things have developed really since particularly my colleague did studies on some certain adipocyte hormones such as leptin, for example, and from that leptin discovery, Professor Faruqi in Cambridge had also looked into leptin deficiency, and there we found that there are novel routes for certain obesity control. And they are also derived from this, what I call importantly, the gut, the most important endocrine organ, the gut-derived pathways per se. So obesity has all these, as you can see, this plethora, oops, sorry, keeps going forward again, plethora of complications. And I think most patients with obesity can present with all these multiple medical, not just medical, but psychological issues as well, which promote weight gain, and more importantly, all these provide very important indications for therapy when they develop these symptoms and these complications per se. The only problem is that all these are massive barriers to how we manage the patients. So in other words, when we see our patient, we have to have the time, and I normally take about 3 sessions each time, because you're going to have 15-20 minutes each session. It's usually after the 3rd session then I can have a complete assessment, and we can consider all these factors. And I think it's important to look at these factors per se. And what I would call here the factors or what I call the 4 M's, the metabolic, the mechanical, the mental, and the monetary things that one will look at. These are the issues that one should think about and take time to discuss with the patient. And as you can see here, that the ones that we probably focus a lot on is when patients have cardiovascular risk, stroke, dyslipidemia, hypertension, cardiovascular disease, heart failure, PEs. Do not forget things about like increased risk of DVTs, hyperuricemia, metabolic deficits like diabetes, and of course sleep apnea as well. There are multiple associations between obesity and depression as well, and I think it's important to bear that in mind. And I think there's something that we need to learn a bit more because of this longitudinal interaction. It's a bit like diabetes and depression. There's also obesity and depression per se, and there's multiple studies that have been shown about it, and the relationship is much higher in women than in men as well. Now, if we look at what, sorry, back again. If we look at what weight loss, what weight loss can do is that it results in the important improvements in all these comorbidities. And in fact, at a recent talk that I gave at the Asian Oceania Conference for Obesity, we talked about the wide range of things that can improve per se when we get this right. So in other words, you have a better reduction in risk of diabetes, cardiovascular mortality, improvements in lipid profile, all these things that can actually result per se. And I think it's important to bear in mind that if you look at type 2 diabetes, 1 in 5 of us in Malaysia, 18.3%, is affected with diabetes. And there's a lot of evidence showing that even with whatever way that you lose weight, you can have a remission of your diabetes per se. And the multiple studies like the Darking Diabetes Prevention Trial have shown that as well. The Diabetes Prevention Program as well. Similarly, the data are showing about weight reduction by dieting on lipids coming down with very low calorie diets. And if you lose 5 to 10% of your body weight, that's able to improve your cardiovascular risk significantly. And these are significant risks in cardiovascular risk reduction even at 52 weeks at 1 year. But we know that larger weight losses have even more benefits if you're able to lose more than 10% body weight. There is this belief that improving obstructive apnea with weight loss is also bad, but the data comes from the 1 year period studies, and I think we need to think about the other therapies for obesity, regardless of non-surgical therapies. There are also things that we use like very low calorie diets for about 12 weeks. That as an intervention has also shown some significant benefits in reducing these comorbidities. So what I'm going to go on to here is the cases. So this is, apologies, it's gone forward too fast. The first case that we have here is basically a gentleman who is quite young, somebody that you probably see at clinic, comes along and really just for a routine checkup. I get these referrals from our healthcare screening usually. And a plethora of risk factors in the family of hypertension, diabetes, coronary artery disease, and he reports this significant weight gain. Now, interestingly, the weight gain that he has been ongoing for the past 1 year, and he has a rather sedentary lifestyle. And with this lifestyle per se, he's asymptomatic. He doesn't really have any significant symptoms, but he is a chronic smoker of 15-pack-year history. And he has this sort of pre-diabetes A1C of 43 millimoles per mole. So anybody who's got an A1C of between 39 to 44 is described as pre-diabetes or impaired glucose tolerant patients. Blood pressure is reasonably okay, but as you can see here, that the BMI is fairly high at 33 kilograms per meter squared. So obesity class 1. Now, I just want to show that these are my two sort of favorite figures that I have. And this gentleman, if you recall, he's George Lucas. And he, apologies for that, he has pre-diabetes. And I think his invention as well also has that too. Now, the major risks associated with pre-diabetes, and this is something that's quite important to take into hold, is that it's really interesting to see. We do know that you have 2 to 4 times the risk of cardiovascular disease and 2 to 4 times the risk of stroke risk. It's the same risk whether you have pre-diabetes and diabetes. It's associated with hypertension, hyperlipidemia. We do know about the risk of retinopathy, which does happen in patients with impaired glucose tolerance. And that's why in patients who have gestational diabetes, we take that very seriously, because if their gestational diabetes is not well controlled, you have a significant risk of progression retinopathy in pregnancy. Similarly, in pregnancy with GDM, if you improve their control too fast, they have a high risk of blindness as well. So you've got to be very careful in pregnancy per se. Nephropathy and kidney disease risk also goes up as such. And I think there is a lot of treatment strategies that are important here to bear in mind, and the evidence of the benefit of weight loss that we can see here. These are sort of carefully designed studies that give us a good evaluation of the effect of weight loss on the natural history of diabetes per se. There's the sort of the one of the seminal studies, this Dar-King study, as you can see here on the left side. This showed a 51% reduction in the risk of progression of prediabetes to type 2 diabetes, and this is really during a 6-year trial. And I think it's important. It goes hand in hand with UKPDS. It shows a legacy effect with a sustained reduction, 20 years later. And you can see that the Finnish study also shows similar results, and similar with the diabetes prevention program. To me, I think when you look at the look ahead study, interestingly, was sort of designed to look at the potential impact of weight loss and cardiovascular events. Now, when that first came out, and I was there at the ADA and ESD when they presented it, the result was initially disappointing because there was no improvement at all in mortality or major cardiovascular outcomes. But regardless of that, in the look ahead, there was still a reduction in the medications for heart disease. There was improvement in blood pressure. There was improvement in the metabolic parameters, and also adipose tissue pathophysiology. And I think the direct study sort of showed us the remission from diabetes at about roughly 2 years in more than 1 out of 3 of the subjects that were in the intervention group. And I think it's important to see what else we can do as such with all this information. Sorry for that. I think it's important to look at the intervention trials here. And I think, apologies, when you look at the intervention trials, you have the Zendos and the Blossom and the Bloom trials, the Sequel trial, and of course the Scale study, which is the 3-year study involving liraglutide per se. And if we look to the patients that have been diagnosed with type 2 diabetes over time, what's really interesting here, in the group that is on the Saxenda, liraglutide 3.0 milligrams, you can see that it has been shown in the dark blue line, it reduces body weight as well as improved glucose metabolism. And this, roughly the study was about a 50-week period of the trial. And this is sort of one of the 4 trials in the Scale program. But in the sort of the 3-year, as you can see, 170 weeks assessment of the Scale data, you can see that there is a significant result after 3 years of treatment. The liraglutide 3 milligrams per se provides significant health benefits in terms of reduced risk of diabetes in patients who are obese and have prediabetes. Now, it also is shown here that there is a regression to normal glycemia over time. And I think it's kind of interesting to see that this is happening to patients while on treatment, that there were more individuals in the patients on the liraglutide 3 milligram group. Roughly about 66% of patients, 2/3, were able to regress, as you can see here, that from pre-diabetes to normal glycemia by about roughly, as you can see, about 160 weeks per se. If you compare that to the individuals in the placebo group, and the more interesting thing is that this result is statistically significant. So, in essence, the second case here is somebody who has dyslipidemia, a gentleman who sort of came to the clinic, who is a busy gentleman. He travels frequently. He actually was able to travel, even during the pandemic times across the border, because he was involved in the vaccine side of things. So, but anyway, he came to the endocrine clinic. He just wasn't happy. He was just feeling tired, and he wasn't even driving, but he complained of fatigue, tiredness all the time, and he had a very, very strong family history of atherosclerotic cardiovascular disease. His father had an MI, which is fatal. His younger brother had an ischemic cardiovascular, cerebrovascular event. And I think this is something that we always fail to take a good family history. It's important to do that, because then you can delineate why the lipid profile is really abnormal here. Hyperlipidemia, total cholesterol 5.9, and LDL cholesterol 3.2, triglycerides slightly elevated. But the worry about him was that he has gained significant amount of weight. And his BMI is 35. It reminds me of the story of this gentleman, and this is Elvis. The reason I showed this is Elvis at the last concert that he had in Indianapolis in 1977, and this is the same year that Apple was actually incorporated, interestingly. But anyway, moving forward, to me, I think the important part is whatever treatment choice should be ideally determine what's the baseline atherosclerotic cardiovascular disease risk. And you've got three particular therapies that you can follow down the road of. And I think in my mind, what's really important is that, you've got dietary intervention that you can go down the road of, which of course we work very closely with dietitians. They have the specialist time to go to, and I think we need to work with very good dietitians to get the optimal results. And when you talk about exercise, the 40 minutes 3 times to 4 times a week, where we come in with the pharmacotherapy, my first line would be obviously statins. You can use ezetimibe, you can use PCSK9 inhibitors, and we've had very, very good success with Repatha. Patients who have hypertriglyceridemia, fibrates can lower them. My own research, we actually looked into the usage of pioglitazone, a TZD, which also lowers triglycerides and increase HDL, and we've had good success with that as well. And I think it's important to bear in mind that weight loss improves all the metabolic parameters in patients with dyslipidemia, increases the HDL, reduces triglycerides. We see that quite a lot, reduction in triglycerides. And of course, the other factors when you lose weight, your BP coming down and better psychological well-being. Now, this is very interesting when we want to talk about this relative contribution of what weight loss can do when you use liraglutide 3 milligrams for ideally for weight management per se. If you look at these particular groups here, this study, which was done by, as you can see at the bottom there, Bayes et al., they were looking at, as an adjunct to sort of a reduced calorie diet and increasing exercise, what happens when you start treating with liraglutide 3 milligrams? Does that result in any well, I would say meaningful weight loss? And what is seen is that you get a meaningful weight loss of about between 6 to 8% versus 1 to 2% with the placebo. And what this analysis to sort of show the relative contribution of weight loss to the treatment effects of the liraglutide on these particular key endpoints of LDL cholesterol, total cholesterol, triglycerides, and HDL. And what you can see here, these cardiometabolic parameters were really improved as such as a result. My third case is somebody who has hypertension. It's a 42-year-old lady who came to the clinic with a classic sort of headache at the back here. We see that quite a lot because I tend to see patients with secondary hypertension with primary hyperaldosteronism and pheochromocytoma and Cushing syndrome. I always look at if patients are obese, the first thing I would look for is evidence of Cushing syndrome, especially somebody who's got hypertension and also hyperglycemia. So this lady came along, she was less active, eating a lot more food. We had a patient recently who was similar to this, but started to develop a moon-like face. And this moon-like face, the first thing that came to our mind was whether she had Cushing syndrome. She had a bit of hirsutism as well, and a bit of hirsutism along the chest, and a buffalo hump. and she had really bad proximal myopathy. She couldn't even stand up from a squatting position. And when we did the 1 milligram overnight dexamethasone suppression test, it was positive for Cushing syndrome. So any patient that you see at clinic who has a family history of type 2 diabetes, hypertension, just like this lady, even if you have a hint of a lower limit of normal potassium, like 3.5, you have to think about, is Cushing syndrome here or primary hyperaldosteronism here as well. This lady gained about 6 kilos in the last 8 months. And the BP is hypertensive and BMI is high. Reason I showed this picture is that Tom Hanks is a very good speaker for our American Diabetes Association program, and he himself has diabetes and hypertension, and how he described his own efforts to try and lose weight, to try and put his diabetes into remission per se. Because I think it's one mind the sort of the disease characteristics of hypertension. And I think there are loads of them that we see this. Patients who come to us with blurring of vision, dizziness. Normally when patients' systolic pressure is more than 170, they're the ones that come to our hospital with risk of malignant hypertension. So they have this neck pain at the back, occipital, nuchal pain, fatigue, palpitations. So if you get palpitations, sweating, and headaches, or nape pain here, you got to think about pheochromocytoma. They can present with chest pains or difficulty in breathing, which is being keeping with left ventricular impairment due to severe hypertension, so hypertensive heart failure. So these are things that one should think about. And I think when you look at the how do we actually treat obesity-induced hypertension, there are multiple ways. A lot of us focus on the antihypertensive therapy, starting them on using the ABCD guidelines. So the ACE inhibitors, along with the calcium channel blocker, is a very good combination, ACE and CCBs, or combining ARB with CCB. And then you've got the addition of either, so use A and C, and then later on will be the B and D, beta blockers or diuretics. So beta blockers, you probably want to use any of the cardioselective beta-1 blockers, such as nebivolol, carvedilol. I use quite a lot of thiazide diuretics, such as you have indapamide or hydrochlorothiazide or bendrafluozide. The fourth line, and we use this in patients who've got primary hyperaldosteronism, is using eplerenone. I prefer eplerenone and spironolactone because spironolactone can cause a bit of gynecomastia. And we've also started to use sacubitril and valsartan combination in patients with heart failure. But anybody who's got a BMI of more than 30 or 27 comorbidities, combination of topiramate and phentermine I use quite a lot as well. The Americans call this the Qnexa. We don't have it here, but I tend to give a combination phentermine starting about 50 and topiramate 37.5 and up titrate that in patients who are intolerant or do not want injectable therapies. The best results I've seen is a low dose of phentermine, about 15, and topiramate, and a big dose, about 50 to 100. Orlistat, I've had very little success because a lot of them have complications with the actual medication. Now, this is a very interesting slide that again, like what was shown earlier from Bezatal. If you look at the adjunct and the effect on the markers of systolic pressure and diastolic blood pressure as well, what the contribution of weight loss to reduction in diastolic pressure is much higher. I mean, it's difficult when you have this kind of analysis to show a causal relationship. But I think it's important to see that treatment with liraglutide 3 milligrams contributes to improvement of these cardiometabolic parameters. So moving on very quickly to case 4, weight management and osteoarthritis. So this 50-year-old lady came to our clinic with a real complaint of left knee pain. And we work very closely with our orthopedic colleagues as well. A lot of the time they refer us cases of patients of severe obesity. And this patient had general osteoarthritis, obviously with the two joints rubbing against each other. And she's post or perimenopausal per se at this stage. She already had elements of dyslipidemia, hypertension and dysglycemia, or diabetes, for more than 10 years. Her BMI was 32 kilograms per meter squared, and she was depressed, and she can't lose weight, and that was the problem. And similar story to Our Lady here. So in a sense, Elizabeth Taylor, who was also diabetic, who was also hypertensive, who was also dyslipidemic, has had 4 strokes in her life before she passed away. And she had very severe osteoarthritis as well, interestingly enough. But if one were to look at the sort of the characteristics of OA, a lot of the time, and as we are most aware of, when we get an X-ray of the knees, this is what we would see, sort of the inflammatory changes in the joints. And then some of these patients tend to have a slightly raised ESR, surprisingly, because of the way that the two joints gnash against each other. And they usually present with knee pain per se. And so talking about the management of knee osteoarthritis, you're thinking about the baseline is exercise and weight control. And we work very closely with a physiotherapist. I think without physiotherapy, we would be struggling a lot in terms of management of this. We also would use intermittently the stronger COX-2 inhibitor non-steroidals rather than just the general non-steroidal, because of the higher risk of gastric irritation. So we do see quite a lot of this gastric irritation in our patients on high-dose naproxen. I tend to use a bit of celecoxib in combination with a PPI like pantoprazole. Very rarely do we resort to intra-articular steroids, because in patients who've got diabetes, like this lady, she would have really high risk of significant hyperglycemia. Glucosamine, unfortunately, can lead to a bit of hyperglycemia. Rarely use that, and I don't usually recommend using opioids, because opioids as well can reduce your hypothalamic pituitary adrenal axis and lead to hypoadrenalism per se. But what's really interesting here is that the amount of weight loss, the further the weight loss, if you're able to lose 5 to 10% of weight per se, and this is, I mean, looking at the data of how in the overall world where obesity is going up and up, and the risk of diabetes is going up, cardiovascular disease, and other issues per se, and you have to bear in mind that, in a sense, that there's a lot of data that was presented by my colleague Lean et al., Mike Lean from Glasgow, that showed that if you look at diabetes, it's one of these conditions which require usually lifelong treatment, and we try and have ways to see whether we can put diabetes into remission. So whether intensive weight management, usually along with our colleagues in primary care, can achieve remission of type 2 diabetes. And not just that, if you look at, between 3 to 10% of weight loss. And as I mentioned much earlier, the direct trial that was actually done by Mike Lean in Scotland, and also he did it as well in the Tyneside region of England with his colleagues. And what you can see is that most of these patients are able to have remission of into a pre-diabetic or non-diabetic state of anti-diabetic drugs, and that's what the top slide here shows, the diabetes remission and as well as prevention, and I think that's what's kind of like our target that I have in my cohort of patients, is to tell my patients, can we have remission of your type 2 diabetes? And I think it is a very possible target, a practical target for my colleagues in primary care as well. So case 5 is talking about, very briefly, weight management in polycystic ovarian syndrome. We see this quite a lot in our cohort. I get referred cases from my gynecological colleagues as well as from the health screening unit. So this 39-year-old lady struggling with weight, BMI of 29, has tried multiple lifestyle programs and lots of products that are out there, Herbalife et al., and worked on a lifestyle. She, in fact, was somebody who goes out jogging, but hasn't been doing that consistently. Came back because the weight has gone up by 9 kilograms in the past 4 years. BMI is quite high. up to 33.5 now. And she does admit that the problem is a profound appetite. Now, she's already at risk of developing prediabetes. The A1C is 37, so borderline. So as I said, prediabetes A1C is between 38 to about 44, or 39 to 44, which is the new one now. So she's very, very close to this. But the patients who've got PCOS, these are the things that they are afflicted with, and it's quite severe. So I normally ask my patients whether they have this hirsutism, this sort of lanugo hair that they get around the face, sort of like and the chin here, also just above, like a mustache per se. They get it here along the chest, and there is what we call the Ferryman-Galway classification of hirsutism. So if you have a Ferryman-Galway classification more than 2, that's very significant. And this happens in more than 70% of women with PCOS. And that's really because of this imbalance between female testosterone and estradiol. You have increased aromatization from estradiol to testosterone per se. And because of that, they come to us and presenting with irregular periods. Usually, they start their periods in normal age, 11 to 12, and then once they start hitting 15 to 18, they become more infrequent, and they're very heavy as well. And what's important to bear in mind is that there's a particular criteria called the Rotterdam criteria, designed in 2013, that designated there are 3 things that you need to fulfill. So one of them is to have hyperandrogenism, which is shown by evidence of hirsutism, acne, oily skin, and then you have irregular periods that you can see here, or dysmenorrhea or amenorrhea, or infertility. And then we look for, on ultrasound, you'll find this polycystic ovarian morphology on either transvaginal ultrasound or sort of a pelvic ultrasound per se. Acanthosis nigricans is a very good sign to look for. So normally underneath the armpits or intercrural areas, or at the back of the neck, the nape of the neck. And this is a sign that they're at risk of significant dysglycemia. And I think that's important to bear in mind. So the long-term complications, and these are the risks that these patients face when they have PCOS. We know about the infertility status and risk of preeclampsia and premature abortion. Other obstetrical complications can occur as well, like DVT, high risk of DVT during pregnancy. But outside of this, you're talking about risk of diabetes, prediabetes, metabolic syndrome. When you talk about malignancies, you'll be thinking about uterine cancer, ovarian cancer, higher risk of this happening in this particular cohort. They have 2 times the risk of cardiovascular disease with PCOS. And more importantly, a lot of our patients with PCOS tend to have, we're not talking about just depression. There's a higher correlation between PCOS and schizophrenia. For some odd reason, the 2 of them go hand in hand. So in patients who you do see, let's say they've got some element of schizophrenia, and then they're obese, think about the possibility of PCOS. When you think about management of PCOS, a lot of us, as endocrinologists, we look at their LH to FSH ratio. There's an imbalance. They have a higher LH to FSH, when normally you'd have a higher FSH in normal menstruating ladies. So the LH to FSH ratio is greater 2 to 1. Some criteria say more than 1.6 to 1, but I use 2 to 1. And therefore, that is the metabolic deficit that you want to reverse. And how to reverse it is really weight loss. So you have 5 to 10% weight loss. You're able to get the periods essentially back to normal again. We sometimes use oral contraceptive pill if it's difficult for them to get their periods back again, even because they feel weight loss. Metformin is a very good medication, pioneered by the Australians in an Australian study for PCOS. Rarely do I use anti-androgens. A lot of the time with weight loss is adequate. And then if they want fertility treatments, then of course you go down the road of clomiphene, gonadotropins, and others, including bariatric surgery. So I'm almost finished now. So in essence, when we talk about weight loss for PCOS, it causes a reduction in the hyperinsulinism, reduces the insulin resistance. It also acts on the hepatic insulin sensitivity. It's not on the slide, but it's important to bear that in mind. They also reduce the hyperandrogenism, so decrease aromatization from estradiol to testosterone. It allows regulation back of the menstrual cycle. It improves, more importantly, we've seen in data of patients who have underlying depression and schizophrenia, that those go into remission when they've lost weight, when the periods are back to normal. It's very interesting correlation between two. It's a bit like diabetes and depression, obesity and depression, PCOS and depression, PCOS and schizophrenia. So you have, therefore, a reduction in cardiovascular disease risk factors and type 2 diabetes and dysglycemia, an improvement in hirsutism, and of course the oily skin or the acne that they get at the same time. So in summary, I think it's important to bear in mind that obesity is a very complex and multifactorial disease. I think that's where we fail in our patients, because we only look at one single strata. We look, they're obese, and we just focus on that and just say, let's get the weight down. And a lot of the time we put a label on the patient saying you're obese, and that creates a stigma for them. And I think it's important to bear in mind to go beyond that and talk about the risk factors. What does obesity lead to? The dyslipidemia, the hypertension, the prediabetes, the osteoarthritis, the PCOS. If you focus upon that, then the patient realizes there is an ultimate objective to losing the weight, and to impart upon the patient that losing weight, 5 to 10% body weight loss, keeping to the diet and exercise has significant benefits. Mike Lee et al., as I showed earlier from Glasgow, from the studies he's done, has shown improvements in dyslipidemia, hypertension, remission of diabetes, as well as control of pain with osteoarthritis and the PCOS regular cycles coming back again. And using liraglutide 3.0, there's established long-term efficacy and safety profile in weight management. Lastly but not least, I think it's important to bear in mind that regardless of what we do, and we can tell our patients, to the death point that obesity is important to look after, but a lot of the time, I think what we really need to do is to enhance the patient's ability to look at the long term. And part of the thing that I think we fail to do a lot of the time is what I would call the cognitive behavioral technique, where we get on the patient's side, we're able to understand what's going on in their life. And I think once you get the cognitive behavioral technique right, that's very, very strongly associated with long-term and successful weight loss maintenance. And the key, I think, is self-monitoring as well. And if we're able to see what's the self-monitoring of their walking activity, and now we have a lot of these high-quality sensors, like our watches, our iPhones. We're not that good at self-monitoring food intake. And I think if we're able to have a food diary, it's very laborious. I tend to ask my patients that they can bring a food diary, but rarely do they fill it up, because it needs sort of near constant attention to their food intake. But it's notoriously inaccurate, and most patients underestimate their food intake. So I think the future would be like if we empower the partners and the patient to do sort of real-time monitoring in some ways in the future, and maybe one day we'll have some sophisticated electronic way of monitoring how much they're eating, and because at least we're able to help them along the way. And to me, when I talk about patient empowerment, it's really self-monitoring so that it's for the patient's benefit. It's not really to show us, but really for the patient's benefit. And that, to me, will result in a better outcomes for our patients. And with that, I thank you.
Thanks, Dr. Saiful, for the wonderful presentation and sharing all the clinical cases. Like, it's very important for us as a physician to understand like what type of patients would benefit from the weight loss. So without any further delay, so I now quickly like to introduce our next speaker. Yes. So our next speaker is Dato Dr. So he is a bariatric surgeon at the Sunway Hospital, and as well as he is also working at the Prince Court Hospital. So Dato Ji has earned his medical specialization from France, as well as he has also got the the degree from the South Korea about the robotic surgery. Followed by this, Dato Ji has also been a member of several of the pediatric surgery societies. He has many publications in international and national journals. Not only this, Dato Ji has been featured in many of the radio, television, and then media newspapers as well. So with this short introduction, I would now like to invite Dato Ji for the second presentation, which is on the use of Saxenda in certain clinical cases. So Dato Ji will be talking us about the Saxenda in the next presentation. So over to Dato Ji, yes.
Okay, thank you very much, Sid, for the kind introduction. I hope you can hear me clearly.
Yes, we can. If you can share your slides.
Okay, I'll be sharing my slides.
And for all the participants who have joined, so please post your questions in the chat box. So we'll take up the questions after Dato's session. Yes, Dato, we can see your presentation now, maybe in full screen mode. Yes, thank you. So you can go ahead. Yes, thanks.
So I've just listened to a presentation of my esteemed colleague, Dr. Saiful, and I think he's basically covered most of the things, and I'm not going to repeat what he has said, but I will echo some important points that he has mentioned in his slides. I think one of the most important thing that he has mentioned, especially towards the end, is about patient empowerment. And that is extremely important because patients need to be fully aware of their actions, of what they're doing to their lifestyle, and they need to be the one who is the most actively participating in their own health issues. Now, most of the time, a lot of our patients tend to push that responsibility to doctors, and I think that's not going to be very effective in any kind of treatment if the patient do not realize that they are the main person participating in improving their health. So I'll just be talking about the prevalence and the factors associated with obesity. I think a lot of it has been covered by Saiful. And just to give you a quick overview of anti-obesity medications, which he has also mentioned earlier on. And then I'll talk about the new pharmacotherapy approach, which is Saxenda, the regulation of appetite and energy intake, and liraglutide effects on appetite and energy intake. I'll be talking about some clinical papers with regards to liraglutide, and then I'll be talking about my own personal clinical cases and experience with Saxenda. So if we look at the prevalence and the factors associated with obesity, first of all, I think we all know now that Malaysia is the most overweight and obese nation in Southeast Asia. Number 2 will be Thailand. Number 3 will be Singapore. And if you look at the common denominator of these top 3 countries is actually our food. So this is where environmental factors are very important, and I'll be talking about that in a while. So you can see the trend from 1996 to 2015. There is a definite increase in both obesity as well as overweight individuals. So for among the obese population, class 1 is estimated at about 4.5 million. Class 2 is estimated at 731,000 people, and class 3 obesity, which is morbid obesity, comprised of about 250,000 in our Malaysian population. And this, mind you, is actually a figure from 2015, and that's 6 years old. So there's probably a lot more changes and an increase in this obese population. So have you encountered people like this on the left side, and people who are big on the right. You can see that we may know very slim by nature, and they can eat more than normal portions, and yet they do not gain weight. And on the other extreme end will be someone who eat regular meals, who have normal, so-called normal calorie intake, or they may even be on a hypocaloric diet, and yet they do not lose weight. So we see such variations because there are two extreme ends. There are many factors involved in obesity, and among them would be genetics and hormonal changes. So the underlying cause of obesity is basically an energy imbalance between calories consumed and calories expended. And these are largely influenced by a lot of appetite signals, hormonal signals in our body. And as what Dr. Saiful has mentioned correctly, the gastrointestinal tract is the largest hormone-producing organ in the body. It produces a lot of hormones, and these hormones are very complex, and they do have different effects on our appetite as well as satiety. Now, we have to accept the fact that there are genetic factors at play that determine whether we put on weight easily or we actually do not put on weight easily. And as I mentioned earlier on, there are environmental factors. So these environmental factors include availability of food, availability of good food, and as well as the availability of food throughout the day, like 24 hours restaurants. And then we also have psychological factors where a lot of the conversation among people revolves around food. For example, most of our staff and people that we know will be talking about food, or what we're going to have for lunch, what we're going to have for dinner, what we're going to cook. And if you go on social media, if you look at Facebook or Instagram, you can find that the most popular posts are usually those related to food, related to cooking, related to new restaurants and new kind of food. And if you are constantly being bombarded with such posts and such news about food, then you're more likely to be driven to think about food a lot of time and to want to eat frequently. Sleep deprivation is also an important cause. I think all of us, when we were medical students, we can recall that when we had to study through the night, we tend to eat. There are some people who don't, of course, but the natural tendency is, if you're going to stay up late, you're going to have at least a cup of coffee, maybe some tidbits and some junk food. Physical inactivity is also a leading cause of obesity, and inactivity is something that is very prevalent in Malaysia. It's been shown that Malaysia and Indonesia are among the least active people in Southeast Asia. We do the least number of steps walking a day. And I think we are guilty of, even I'm guilty of some inactivity. Like, for example, I would try to park right in front of the shop as close as I can to the shop, and I don't want to walk too much. I think there are also many factors that influence our inactivity. One is the weather. The second thing would be about security, jogging in the park alone. During dusk, it can be a risk, or trying to cycle or walk on the streets. It's with our rates of road traffic accident in Malaysia, it's quite an intimidating thought. Of course, the quarantine doesn't help. Most of us gain weight during quarantine because, like I said again, we post our food and then we try out new recipes, and a lot of us are cooking during quarantine because we have nothing much else to do, or we'll be ordering food from the delivery apps. Now, what is the problem with adiposity and obesity is that the adipose tissues produces a lot of cytokine as well as a lot of hormones that leads to chronic low-grade inflammation. And this chronic low-grade inflammation, as we all know, inflammation now is the root of all medical problems, including cancer, hypertension, cardiovascular diseases, type 2 diabetes, and of course, increased adiposity leads to increased insulin resistance. So I'm going to take you through an overview of anti-obesity medications. I will not mention too much because some has already been presented before. So I have no experience using topiramate like what Dr. Saiful has, but there are 3 medications that is available, I think, even among the GPs. These are probably, these 2 medications are quite commonly available in the clinics. So one is Orlistat, and personally, I do not like Orlistat as well because it produces a lot of GI symptoms, and it can be socially very embarrassing because there might be an uncontrolled diarrhea or incontinence because of Orlistat. So basically, Orlistat inhibits lipase, and therefore fat and fatty acids are not being absorbed, and they are being passed out in feces. Of course, there is weight loss with Orlistat, but it's difficult. There are a lot of people who complain of the GI symptoms and will then stop the medication. Phentermine, under the brand name of Duramin, is again a very long established medication that's available, and it basically is a sympathetic amine that releases norepinephrine in the CNS. So what happens is that the norepinephrine or noradrenaline that's been released stimulates the propionmelanocortin pathway, and that stimulates the production of melanocyte stimulating hormone, and that in turn will then attach itself to a melanocortin receptor, and this is the hypothalamus pituitary pathway, and that actually reduces the appetite. So this is how phentermine works by reducing appetite. Now, I would like to highlight this because yesterday I saw a new patient that was on both phentermine as well as liraglutide, Saxenda. So it is. I'm not too sure why the general practitioner has started both this medication, but liraglutide has very similar effects as well on the propionmelanocortin pathway. So it is not. It's not a good idea to actually combine phentermine as well as liraglutide. So there is, of course, weight loss with phentermine, but there are a lot of side effects that come along with phentermine as well because it is a sympathetic amine. With increased sympathetic activity, there will be an increase in blood pressure, there will be tachycardia and palpitation, and there will also be insomnia. So it's not, these side effects are quite undesirable, and a lot of patients again do not like these effects, and they eventually will drop out from the treatment. So we've come a long way in terms of the research and development of obesity and type 2 diabetes medication. 30 years ago, the perception of diabetes was something very mild, no big deal. And it was not until in the early 1990s that we realized that if we can control, we can achieve good glycemic control, that we can actually prevent the complications of diabetes. And that has led to the development of multiple anti-diabetic medications, and eventually emphasis on obesity and the overweight population began in the year 2000, and that has led to development of pharmacotherapy for obesity, as well as bariatric surgery for obesity. So in our own CPG guideline, we have recommended different therapy for different BMI levels. So if you are on the class 1 obesity category, you may want to consider anti-obesity medication. But if you have severe obesity or morbid obesity, your patient may want to consider surgery, bariatric surgery. But if you look, what is common to all this therapy is lifestyle changes, which includes dietary changes as well as physical activity. So I can actually summarize this. This is actually on my own personal website. You can see that we have the 3 treatment arms. Medication, we have endoscopic procedures like balloon, and then we have bariatric surgery. And the center of this 3 therapy would be behavioral modification, diet, lifestyle changes, which includes dietary changes, and physical activity. So the center of all this therapy is still behavioral modification. That's extremely important. That's the reason why we need to spend time with our patient. We need to identify the causes of obesity. We need to build a very good rapport with them, and we need to empower the patient so that they take the most active role when it comes to treating their overweight or obesity issue. If there is no behavioral modification, if there are no lifestyle changes or meaningful lifestyle changes, all of these 3 therapy will not work in the long term. It will fail eventually. Okay, I think I'm not going to mention this anymore. So we now have a new pharmacotherapeutic approach, which is liraglutide 3 milligrams. So what is liraglutide? It is actually a analog of GLP-1. Yeah, so GLP-1 is glucagon-like peptide 1, and it is predominantly secreted in the GI system, mainly from the L cells, but it is also being produced in the brain. So how do we regulate our appetite and how do we regulate what we eat? It's quite interesting. There are 3 pathways on how we regulate our eating. Number 1 will be the homeostatic eating, which you feel hunger and then you seek out food. I think this is the most primitive instinct that drives us to look for food when we are hungry. So the hormones involved here will be ghrelin, which increases hunger, and the hormones that increase satiety, that means it tells us to stop, will be GLP-1, peptide YY, and so on and so forth. Now, it's important to have both hunger and satiety. Hunger makes us seek out for the nutrients that we need in our body, and satiety stops us from overindulging or overeating. So some animals do not have satiety. Can actually go, for example, you can feed your goldfish until it literally dies from eating. And then we have the hedonic eating, which is we live to eat. Okay, so first is eat to live, and the hedonic eating is actually eating for pleasure. So we find a lot of pleasure in eating. There are certain foods that trigger certain hormones that make us happy. Certain types of food, maybe it can be something from childhood, something we grew up with, something traditional, or it can be something completely new that stimulates this happy hormones in our brain that gives us a lot of pleasure. And this includes serotonin and a lot of opiate-like hormones that is associated with delicious food that we derive pleasure from. So, okay, and of course, the last one is something more of a frontal brain function, in which is a more higher thinking. It's a more executive function where we can actually decide. And this decision basically depends a lot on our behavior, on our thoughts, and our feelings. So this is the part where if you look at the hedonic eating as well as the executive function of eating, these are the two components that we can have a lot of control over. We can have that executive decision. We can make that executive decision when it comes to eating, whether we should go on eating, whether we should be eating the kind of food that will bring us nutrient or is going to affect our health. So we can make that executive decision, and we can modify our behavior. This is the scientific basis of how we can actually control our eating. So what's the effects of liraglutide on appetite energy intake? So GLP-1 secretion, basically, as I've mentioned, is produced predominantly by the L cells of the gut and also by neurons in the tractus solitarius. And GLP-1 receptor, on the other hand, is expressed in the brain, in the lung, the heart, the pancreas, the kidney, and of course in the GI tract itself. So as I've mentioned before, there are two components here. There is satiety and there's hunger. And the pathway that's involved in satiety would be the propionmelanocortin pathway, as well as the cocaine amphetamine regulated transcript pathway, which influences our satiety. And then we have the neuropeptide and the agouti related peptide pathway, which affects hunger. Now, agouti related peptide can actually cancel the POMC pathway, and that actually can prevent us from feeling satiety. Now, it has been proven that there are some mutations in certain individuals where they there might be some mutations in the melanocyte stimulating hormone, or there might be an actual decrease in the melanocortin receptors that actually reduces our feelings of satiety, and there might be an increase or an overexpression of agouti-related peptide, which makes us feel hungry all the time. So, and it's been found that generally in obese individuals, there are actually such mutations in our brain. So we like to, it's quite frequent that we hear when we tell people that, we hear people saying that obese individuals should just do more diet and exercise. They should eat and then they'll be fit. It's not as that, because some things are really beyond the control of these individuals. For example, their genetic factors or the mutation that is at play. So we have to be more sympathetic to such individuals. Don't have the blame game, because everyone else in their family and their friends would have blamed them in some way or another for the state that they are in. So we as physicians, we need to be more sympathetic with their condition. We need to hear them out. We need to let them identify what they think their cause of obesity is. I'm sure that they will also tell you that, yes, I do have some unhealthy eating as well. I do have some bad habits, but a lot of times I try to be sensible when it comes to eating. I try to eat less, but I do not achieve the target that I want. I do not achieve the weight loss that I would expect to see. And that has made me frustrated, and this frustration has led to depression, and that depression has further driven me to seek more pleasure in eating. So liraglutide helps to increase satiety, and it helps to reduce hunger. Now I'm going to quickly go through the clinical papers of the scale phase 3. So there are a lot of papers to date. I've done a quick search and then about approximately 80 papers on liraglutide. But these are the notable ones that have been published in New England Journal, The Lancet, JAMA, and of course the International Journal of Obesity, and also in Diabetes Care. So I'm going to start off with this paper by Van Kant. Van Kant talks about the effect of liraglutide on gastric emptying, glycemic parameters, appetite, and energy metabolism. Now, they looked at liraglutide 1.8 milligrams versus 3 milligrams, and both of this liraglutide versus placebo. So they found that there's actually an improvement in satiety with liraglutide. There's also a good feeling of fullness with liraglutide as compared to placebo. And there's also less hunger, and there's less actual food consumption when patients are on liraglutide 3 milligrams. Now, as far as gastric emptying is concerned, there was actually not much of a difference between liraglutide 1.8 milligrams and 3 milligrams, but there is definitely more satiety and less hunger with 3 milligrams of liraglutide. Now, this study also shows that there is a 16% reduction in calorie intake or energy intake, but there's no actual increase in energy expenditures. So liraglutide is probably not associated with an increase in energy expenditure. The weight loss that was seen in liraglutide is also an effect of a reduction in appetite, and it is not associated with nausea and vomiting, because you can see that there's still significant weight changes despite not having vomiting or nausea. So basically, as I've talked about the hedonic control of food, how we react and how we derive pleasure from food, it has been shown that liraglutide actually reduces this such activity in the brain to seek out pleasure from food. So the other study that was published in New England Journal and they have put these patients on liraglutide 3 milligrams for 56 weeks. And basically, they have found that with liraglutide, there is a 8% decrease in body weight as compared to placebo of 2.6%. And this is statistically significant. Now, if you look at all the papers and all the different research, and we put them all together, we can actually see that there is significant weight loss or meaningful weight loss when patients are on liraglutide 3 milligrams as compared to those who are on placebo. So we look at the scale obesity and pre-diabetes, we look at the scale diabetes, we look at the scale and sleep apnea, and we look at the scale maintenance, and we can see that there is a definite significant weight loss of at least 5% to up to 10% across all these studies. Now, the safety, this liraglutide 3 milligrams is actually a very safe medication. There are generally very minimal gastrointestinal adverse events. There are actually fewer major adverse cardiovascular events as compared to placebo. So we can conclude that liraglutide does not increase any cardiovascular events. As far as gallbladder disease is concerned, numerical imbalance here means that the numbers are slightly more as compared to placebo, but I would conclude that because liraglutide actually decreases appetite, some patients may actually unintentionally be doing a form of intermittent fasting because they have no drive to eat. And what actually happens is that when you don't eat or when you do intermittent fasting, there's actually a lot of stasis in the gallbladder. When there is stasis in the gallbladder, there will be crystallization of calcium or the cholesterol crystals may form, and that might actually lead to an increased risk of gallstones due to such stasis. So it's actually quite predictable, and it's actually quite natural that there might be more gallstones with liraglutide treatment. With acute pancreatitis as well, there is slightly more increase of risk of pancreatitis with liraglutide, but it is still very low and not statistically significant when compared to placebo. Neoplasms, of course, we're talking about liraglutide that is on 56 weeks, liraglutide 160 weeks, 3 years, is not going to show you any meaningful reduction in cancers. Although we know that if there is weight loss, there's definitely going to be a reduction in neoplasms, but this would actually require long-term studies of at least 10 years. But there were some cases reported of breast cancer, and there were some unequal numbers when you have the liraglutide group compared to the placebo group. But again, like I've said, I do not think that there is an association between breast cancer and liraglutide, and it could be just coincidental. What about depression and other psychiatric adverse events? With the use of liraglutide, there is actually no difference between the two groups of liraglutide and placebo. but you do need to be cautious because a lot of patients who are obese and a lot of patients with overweight problems do have depression. They do have pre-existing depression, and some of them may actually have suicidal tendencies even prior to treatment. So that's the reason why we must develop a very good relationship. We must find out from them what their problems are, and echoing what you need to have multidisciplinary. It'd be good to have in the counseling, and ideally, if you can, have a psychologist, a clinical psychologist on board, so that they can actually monitor as well as give a lot of psychological support to the patients while they are on treatment with liraglutide. This is a latest paper by Wharton, and they actually looked at obesity. They looked at the obesity rates and the use of liraglutide 3 milligrams versus placebo, and it's been shown that there is a 6% reduction of weight with liraglutide. Okay. All right. So just to mention a little bit about the method of administration, we start off liraglutide at 0.6 milligrams daily, and it's a recommended increment of 0.6 milligrams every week. But in practice, this can vary. This interval between one dose to the other can actually be between 1 to 2 weeks. So it depends on what your patients, if there are any reported gastrointestinal events. Obviously, if they're going to be nauseated and they may have an episode of vomiting with 0.6 milligrams, it is not advisable to increase to 1.2 within a week. Perhaps it would be better to maintain it at 0.6 and observe the symptoms. But of course, if they do have pain, then it is best to stop the liraglutide treatment and then maybe restart it after some time. So do not start off with the highest dose, and always do an escalation of dose until you reach 3 milligrams. And to achieve meaningful weight loss, we need to have patients on 3 milligrams and on liraglutide for at least 12 weeks. So in summary, liraglutide 3 milligrams has a very good weight loss efficacy of up to 9.2%. So I generally tell my patients to give them the correct expectation that might be a weight loss of between 5 to 10% of body weight. Liraglutide, of course, has a dose-dependent effect. So as you increase the dose of liraglutide, you're going to see a more pronounced effect of reduction in appetite and reduction in calorie intake. There is a 80% risk reduction in the development of diabetes, as shown in the SCALE pre-diabetes trial, where subjects who are on liraglutide only 2% had developed diabetes, as compared to 6% of the placebo arm which developed diabetes. So if you were to incorporate behavioral therapy or intensive behavioral therapy, then you will see an additional weight loss, and you will see less attrition, less dropout rates, and a better maintenance of weight loss. So again, liraglutide 3 milligrams is the ideal dose that we want to achieve eventually. And we can also see an improvement in cardiovascular risk factors, as well as dyslipidemia and hypertension with patients on Saxenda, not just on diabetes. I'm going to share with you some of my own personal clinical cases. There are 3 subgroups among my patient population on Saxenda. One will be those who are on pharmacotherapy alone. The second one will be those who are planned for bariatric surgery and they have been given Saxenda pre-operatively. And there will be another group of patients who have already undergone bariatric surgery. Just need a couple more to achieve their weight loss goals. And this comes under the post-operative category. So we have this gentleman here who came to see me with a BMI of 36. And after 12 weeks of, just 12 weeks of Saxenda, he has already achieved a BMI of 30. And of course, the Saxenda was continued beyond 12 weeks. But I'm just trying to highlight the fact that you can actually reduce this much even within a span of 3 months. So his weight loss has been quite phenomenal, and he lost about 20 kilos, and he's now closer to his weight loss goal of 72 kilos. He had a reduction of 20 centimeters in his waist circumference in just 10 weeks. I have another patient who is actually a doctor herself, and she's been trying to conceive. And she had an initial BMI of 35, and she was started on liraglutide 3 milligrams, and eventually achieved a BMI of 32. You can see that there is a significant further reduction of weight once she was on a dose of 3 milligrams, and she has also achieved a good 6 kilo weight loss and a 9 centimeters waistline reduction with liraglutide. And she has actually recently got pregnant, and that shows that with weight reduction, we can actually treat infertility issues. So I have patients who are probably more suitable for bariatric surgery, but for some reason do not want to undergo surgery and have opted for Saxenda. And this is also a good example where they are able to achieve some weight loss and helps them break that cycle where there is a continuous weight gain, depression, frustration, eating more, and weight gain. So we managed to break that cycle and hopefully give them a boost in their confidence as well as motivation to drive them to lose more weight further. So you can see that she has reduced her weight quite consistently, and of course this was at the beginning of the MCO, and she was literally isolated from everyone else, and there was a bit of a weight gain because she could not continue with her exercise outdoors, and there was very limited food choices, and she ended up eating a lot more unhealthy food. And we have, of course, counseled her and restarted her back on 3 milligrams of liraglutide, and she continued to lose weight. So we have another example here where there's a reduction of BMI 35 to 33, and actual 5 milligrams of weight loss. You will notice that there's actually a lot more significant inch loss as compared to weight loss, and I will show you why in a while. We have some pre-surgical patients that we want to achieve some weight loss prior to surgery. You can see that they have actually lost weight after starting on liraglutide, and the effects are so good that now the patient is actually reconsidering surgery, which I see positively. So I do encourage my patients to continue if they feel motivated and they do see good effects with liraglutide. So we actually measure their body fat mass using body composition analysis machine We actually look at the fat mass and not just at weight loss, because weight, as we all know, we are 60% water by weight, and weight is also determined by skeletal muscle mass as well as fat and water. So for example, a lot of people during the fasting month may think that they have lost weight, but in actual fact that they may have actually just, we want to see is meaningful weight loss, which is actually fat. And we can actually see that in this case, there is a 9 kilo of fat loss in 8 weeks. 9 kilos of fat loss in 8 weeks. Now, if you go to the market and you try to buy 1 kilo of fat, you can then get a picture of how much fat there is in 1 kilo. So losing 9 kilos of fat is an amazing achievement. You can also see that when patients start to eat better with behavioral therapy, with a lot of dietary support and a lot of encouragement to do resistance training, not just cardio, but resistance training, they actually increase their skeletal muscle mass, which is going to have beneficial health effects. Don't worry about patients increasing their muscle mass. They will never look like Arnold Schwarzenegger. They're just going to be a lot healthier because they have better improved muscular function, and they actually have increased their muscle tone in their body. So, okay, all right. So we have another patient that was on Saxenda for 12 weeks and managed to decrease 3 kilograms of body fat mass. Of course, this patient also had a bit of a muscle mass loss, and it's just quite insignificant. I think it's just 0.5 kilos of muscle mass loss. So I do have a lot of patients who have undergone sleeve gastrectomy, and they have lost like 80% of their extra weight, excess weight loss of 80%. And they just needed to lose another couple more kilos to achieve their target. And such patients have probably plateaued their weight loss after surgery, and they needed a boost. And this is where I use Saxenda as an additional boost for their weight loss goal. So I have a patient here who has been plateauing at BMI 30, couldn't break that BMI 30 scale, and I started her on Saxenda, and within 2 weeks she was able to lose 2 kilos, and she looks, and you can see that there is a significant change in her weight, even by eyeballing without looking at the scale. If we actually look at the scale, there is an decrease in her weight, and there's also a reduction in her waist circumference of 2 centimeters. Now, among my patients, these are what we have found to be the side effects of liraglutide. We found that the commonest is nausea and vomiting, and well, the other thing would be nausea and vomiting. So if you look at nausea, only 3 people were nauseated in the first week, and only 1 person actually vomited in the first week. When I say loss of appetite here, I mean those who have really extreme loss of appetite where they completely have no drive to eat, and they have actually not eaten, literally not eaten the whole day or 24 hours, in which we were quick to recognize this problem because we see them regularly, and we actually tell them that they still need to eat their proteins and eat their nutrients despite not having any appetite to do so. Otherwise, they will end up losing skeletal muscle mass and not just losing fat mass. So in conclusion, obesity is a very complex multifactorial problem. We need to be more sympathetic and empathetic towards their problem, spend more time, discuss with patients, ask them to tell you their reasons, what they think is the cause of their weight gain, and then spend more time throughout their weight loss journey, see them more regularly so that they are more compliant. This will make sure that they do have meaningful weight. Liraglutide is a very good weight loss therapy option. It is safe and effective, and as in the paper where they had looked at liraglutide patients, their follow-up liraglutide patients for up to 160 weeks, that's 3 years. This paper is by Leroux, and it was published in 2017. It shows that even with just with the current clinical evidence, patients can be safely on liraglutide for up to 3 years. The very minimal side effects seen in this research paper, as well as in my population of patients, we can achieve an average of 6%, but I frequently tell my patient that we are looking at 5 to 10%. With more behavioral changes, you will be able to achieve better weight loss. And of course, meaningful weight loss and maintenance is seen with at least a minimum of 12 weeks and above of liraglutide. So do not stop short at 2 months, do not stop short at 10 weeks. You have to continue beyond 12 weeks to see significant weight loss with liraglutide. And I'd like to end by saying that you can actually follow me on Instagram as well as on TikTok and at this Dr. Tik Fuji. So thank you very much for your attention.
Thanks, Dato, for the wonderful presentation on the Saxenda, as well as sharing all the clinical cases. It's very interesting, all the cases. So I'll share, we'll start the Q&A, but just before that, a quick, one slide that I would like to share here about one of our program that we have. This is known as Sahabat Saxenda. As both the speakers have mentioned that only pharmacotherapy might not help, so it's diet and exercise should go hand in hand whenever it's a case of obesity management. So that's why from Novo Nordisk we have this commitment, and then we have come up with this program known as Sahabat Saxenda. So what is this program? It's the program wherein your patients who are on Saxenda, they could enroll themselves into this program. And we have in-house counselors so who can call your patients, and then they will understand what's their lifestyle like. And based on that, they recommend proper diet as well as exercise advice to the patients so that the patients can achieve a very good weight loss. So handing over only the pharmacotherapy may not help. So with that, this diet and exercise.
Find a place to.
Sorry. So with this, now I would like to open up for the Q&A. Just stop my presentation.
How much pork should I order? Then what's chicken rice? You want something to eat, mommy?
We have chicken wings and fish.
Okay, so maybe we will first go to a few of the questions that we have received and here. So in the chat box, so we have received few of the questions. So I'll be going through one by one. So one of the doctor has already mentioned here is that a very interesting thought has mentioned that I would usually ask my patient to take photos of their food and show me the next consultation. So that's a really good advice that you are already following. So to see what kind of a diet, whether they are following it or not, or whether they are still eating nasi lemak and the one that Dr. Saiful has showed in the morning. So whether they are following it or not. Yes, so if somebody has raised hand, if not, then I'll just quickly move on to Dr. Saiful's first question that we have received is that why is chondroitin or glucosamine is not recommended in osteoarthritis?
Okay, can you hear me?
Yes.
Yeah, okay. First of all, that was a great talk by Tik Fu. Really enlightening. Thank you very much. I learned a lot. Now back to osteoarthritis. Okay, hands up, because I'm an endocrinologist. I'm not an osteopath or orthopedic surgeon, but the reason why, especially chondroitin, or should I say glucosamine, there's a slight contraindication in patients who have diabetes because it increases risk of diabetes getting worse. But I think when you talk about osteoarthritis, this is type 1 and type 2 collagen as well. And when you give certain therapies like chondroitin or glucosamine, there is some minimal evidence, not really in terms of attenuating type 2 collagen, but there's some minimal evidence using other therapies like Mobic, which are, COX-1 and COX-2 inhibitors, may be able to help. But if you want to say an absolute contraindication not to use it, there isn't. But in the context of a case of somebody's obese with risk of prediabetes or diabetes, then we would not use or glucosamine per se. So that's the answer to that question specifically.
Okay. Thanks, Dr. Saiful. Dr. Suktachan has raised his hand. So if you can unmute and then you can ask your question to our speakers.
Doctor, I would like to inquire, can there be an age-adjusted dose to liraglutidine? Maybe instead of the full 3 milligram, could one adjust it to 2.4, taking into consideration the age and the GIT symptoms one may have? Because I feel it should be adjusted to the side effects of the Saxenda. Thank you.
Is that addressed to me or Tikfu?
Maybe we start with Dr.
Saiful shall answer that.
Okay. So I think it's important to look at the comorbidities of the patient more than the age per se. So if the patient does have any increased risk of gastritis or gastroesophageal reflux, stomach pains and history of that, then you're right. You probably want to keep the patient at the low dose. But I tend to find, and this is just anecdotal from our own experience, we try and titrate them up as per the regimen. But if they have the side effect at, let's say, at 3 milligrams or 2.4 milligrams, we go back down to either 2.4 or 1.8. Leave them on a longer time on that, and then gradually bring it up if you find that the results of weight reduction. And I normally review my patients quite often. The benefit of our clinic is that you can review them on a monthly basis. So to me, on a monthly basis, we're able to see whether that weight goes up or down. You're right. A lot of our patients, if you want to ramp up and get the results at about 12 weeks, you want to see an up titration of the dose. But in cognizant, or albeit being aware of the risk of side effects. And I always tell my patients, by about the 12th week, 4 to 12 weeks, the nausea, the vomiting, that should settle down. It also depends on the kind of food that they take as well. That also increases their risk of those side effects. So if you find patients who are older and they have more comorbidities like renal dysfunction or gastritis and other issues like that, and you're afraid of the risks of side effects, then yeah, you can keep it at a lower dose and probably titrate it a bit slower than on a weekly basis, maybe every 2 weekly or 3 weekly basis. But it's very individualized. And what I would say is the patient that you have in front of you will decide, it's a teamwork with you and the patient together. But I always tell my patients, whatever side effect, and the main nausea, it decreases over time. That's what you just have to get used to. It doesn't get worse, it gets better. And I think giving that positive message is important.
Just would like to share, Doctor, my personal experience. I'm on liraglutide. I found 3 milligrams a bit too much. I stepped down to 2.4, and it has been quite good for me. I'm not trying to boast, but I've managed to lose about 20 kilos with a lot of calorie watch, a lot of exercise, and I'm already 65. So I'm a bit worried that if I go out to 3, it may activate all the GIT symptoms which I had. Thank you.
Saiful, you want to take that?
That's great to know. I think it's great that you've done well, even with 2.4 milligrams. I think there's something wrong with titrating the dose to suit your personal need on a case-to-case basis. But that's the reason why Saiful and I had mentioned from the beginning that it's very important that we keep a close watch and a good relationship with the patient. We monitor their symptoms, and if they don't have GI symptoms, and if they want to achieve more significant weight loss, then 3 milligrams is recommended. But in individual cases where there are symptoms, or if the patient feels that they are more comfortable at a particular level, there's nothing wrong titrating at. Congratulations, well done to your weight loss. I think you are an inspiration to a lot of us and to a lot of your patients.
Yeah, I echo Tikfu. That's an amazing amount of weight loss. Rarely see that, but my understanding with the liraglutide 3.0 dosing as well, the regimen that was designed, I think is based on looking at the scale studies and the studies that have been done as well. The way it's titrated up is to try and reduce the possibility of gastrointestinal symptoms. So it's not, you're not ramping it up on a daily basis, and that's why you can always chop and change in how you go up the dose. But the data that's most impressive is when you are able to get up to about 3 milligram dose. I used to remember before Saxenda came out, when we're using liraglutide on its own in our type 2 diabetes patients predominantly for hyperglycemia, and when we're looking at leader data, that we had been able to elucidate ourselves, and this is before Saxenda was about weight, of titrating it upwards from 1.8 to 2.4. So you have to have 2 pens, really. You got to 1.8 on one, you have another pen, you got 1.2.
2 injections,
yeah, 2 injections before that. I remember going up to 3 milligrams as such. But interestingly, from our own cohort that we have looked at, we're not looking at just the weight reduction. I think a lot of people focus just weight numbers down. I like to look more on the cardiometabolic parameters, the dyslipidemia. I've had patients where cholesterol is like 6 gone down to 3. I haven't even put them on a statin. Blood pressure coming down. They came with blood pressure 174 over 100. And when they've lost their weight at about 3 months down, their blood pressure is down to 140 over 80. And that's off, not on any antihypertensive. So it's actually a big boon for patients that you're not expanding their pharmacotherapy, which causes more and more side effects. You're able to get them off medications. And the problem with us as diabetologists is that we looked at our data, and on average, each patient is taking about 6,940 tablets a year. So that means they're on 4 oral hypoglycemics, 3 antihypertensives, 2 for the lipids. And we've been able to see that patients who are on sulfonylureas, they put on weight. Thiazolidines or pioglitazone, they put on weight. And if you're able to target the weight properly, you're able to reverse, should I say, put them into remission without adding more tablets. So anyway, well done to you for your weight loss.
One of the ways I approach a patient when they ask me about side effects is that I would then ask them back a reverse psychology question, and I say, yes, there are effects. There are side effects from medication and surgery, but what about the side effects of the stuff that you do, the stuff that you put into your body? Black-colored sugared water called cola. What about the side effects of putting in nitrosamines that is found in burgers and sausages? What about all those chemicals that you eat? What about this coloring that you eat? What about the stuff that you smoke and you push into your lungs? Those are worse than any medication, So just to twist them around and show them the other side of side effects, and then they will be able to make a better judgment between benefits versus risk of starting any treatment.
I think that's a great trick. and I always find that some of our patients, they come to us and then line up the supplements that they have.
Yeah.
Supplement X, supplement Y, and say, what about this, doc? Can I take this kind of? And I always say there are, I call this N=1 study, testimonial. one testimonial here. There's no randomized control trial to prove its efficacy. Yeah.
Level 6 evidence, grandmother tale.
Yeah, that's right.
Yeah, thanks to both of you. So yeah, so we have Dato Dr. Yep. So yes, you can unmute yourself and you can ask your question.
Yeah. Just because generally, how long should the patient be maintained with this liraglutide? And at the same time, I think because of the cost, sometimes they say they want to stop, and will there be any rebound phenomenon when they stop the medication?
You want to go first, Saiful? Or shall I?
Go ahead, Saiful, no worries.
Okay, so the data, if you look at the scale studies there, and I think Saiful also helpfully showed the data that Karen LaRue from Dublin did as well on liraglutide 3.0 milligrams. To me, I'm going to take a step back, and our population in Malaysia is slightly more skewed from a lot of the scale studies. Look at the whole generic population, right? In Malaysia, we have a rather carbohydrate-laden, heavy population that love food, and I think it's very difficult to say, okay, this is the X amount of time that should be on it. I tend to have, anecdotally, when I see my patients at clinic, after about 3 months, in Malaysia, cost is such a big thing. And they will say, okay, look, the data can say, yes, up to 52 weeks and 104 weeks and up to 2 years and 3 years. However, the pocket demands and as we know, insurance cover for obesity treatment, it isn't really there. And a lot of my patients, by about the 3rd month, they would say, Doc, I've lost this much weight, I can't afford anymore, I got to stop. And you have to assist them along the way. So my strategy has always been, the Saxenda or liraglutide 3.0 is great at turning off the pathophysiology in the appetite center, right? The next step after that is to try and encourage them to stick a very low calorie diet. I tend to go, rather than the old-fashioned, which is you put them on a very low calorie diet, then you go on to a medical therapy. I use the opposite way. I start with a GLP-1 receptor agonist at high doses to suppress the action on the hypostrema and the hypothalamus. Once they find that the cost is an issue, then we switch over to a very low calorie diet to keep the maintenance of weight loss going. Because you're right, a lot of the time that you will find with there's this rebound in weight that goes up, but not a significant amount. But you want to continue the weight loss for as long as possible. And then you use other therapies to continue on that. Other pharmacotherapies like using phentermine with topiramate, I find them laden with side effects. They come with palpitations, their heart racing. They just don't feel great on it. Topiramate also causes a bit of dizziness as well. So I just go on to the next step of VLCD, or very low calorie diet, to continue on further weight loss, and go from there. I don't know what you think, Saiful. What have you?
That's a great approach. That's a great approach. I mean, we all set our expectations with the patient, and when we start them on any kind of therapy, we always talk about what to expect and what you're gonna look for. So I always sit down with them, I talk with them, and try to get what their target weight is. So they will always tell me a particular target weight, what will be their happy weight and what will be their very happy weight. And we will discuss along those lines. And then we'll tell them that, okay, if you want to achieve this much and this much, then maybe this therapy is more suitable for you. If you just want to achieve a certain particular target, then this therapy may be better for you. And so the center of all this therapy and all this discussion always comes down to behavioral, meaningful behavioral changes. It is not about the therapy, because all therapies will fail if we do not empower the patient, if we do not focus on behavioral therapy. It is about using medication or using surgery or using any other methods as a tool to assist them in their lifelong journey of weight loss and weight maintenance. It is a tool. So I tell them, it's up to you how long you want to use this tool for. It may be just for a little while, it may be for a long while, until you are comfortable, until it becomes a routine, until you can actually achieve behavioral changes, you can achieve that lifestyle change that you want independently without the tools. That will be our ultimate goal. And when we set this expectation right from the beginning of treatment, it's going to be easy to decide when we can stop whether we're going to continue the treatment.
Okay, so moving on to our next part, so of the questions. So there are a few questions on the indication as well. So probably I can quickly give an update on the indication. So indication currently that we have is in adults, like more than 18 years, up to 75 years, we have data. So in BMI more than 27 to 30 with comorbidities, and BMI more than 30. Pediatric patients, currently we do not have an indication in Malaysia. And there was also one of the question regarding the whether the drug is helpful in obesity due to genetics and not overeating, any kind of genetic disorder, so that is resulting into obesity. Although in scale trials, so we have excluded such type of patients. So I just leave it to Dr. Saiful, or like, what do you think about it, the type of patients?
Yeah, I mean, there are multiple genetic syndromes that are out there. The one that really sticks in my mind are the studies have been done by Professor Faruqi in Cambridge looking at congenital leptin deficiency patients, and the data she published from that. I personally, we don't see that in Malaysia. I think what we see, Prader-Willi, we do look for that, the hyperphagic symptom patients. We do have one quite recently with that. A lot of the other endocrinopathies can lead to difficulty in getting off weight. So patients who've got Cushing syndrome, even acromegalics, and significantly hypothyroid patients. The one that I normally tend to look for are women who come to me and have infertility, gain, let's say, 20, 30 kilos over a couple of years. They have this acne and they look like someone's got PCOS, but actually what they've got underlying all that is Cushing syndrome. So, but don't forget about iatrogenic weight gain. A lot of the time, we ourselves give medications to patients which causes weight gain. Not just genetic symptoms. So patients are on sulfonylureas, on insulin, on pioglitazone, and these are just anti-diabetic medications. But you look outside of that, patients on steroids. I get to see a lot of patients on antidepressants, and they cause weight gain. Amitriptyline, massive weight gain. Any of the tricyclics, mirtazapine, a high dose of mirtazapine, 45 milligrams. Some of the depot medroxyprogesterones causes weight gain. Even antihistamines, patients to come to us, right? And the generic name, I think, is diphenhydramine. And these things are really horrendous. So we cause the weight gain. So a lot of the time, I always take time to look at the drug history. What drugs they're on that can cause weight gain, and not just genetic side of things that we look for too, or other sort of endocrinopathies. Yeah.
Thanks, Dr. Saiful. So I move on to Dato Ji now. So he has to leave for another meeting. So I'll be asking him one of the questions. So Dato, my question to you is that since you have mentioned in your slides about certain side effects in your patients that you have seen, like nausea, or maybe some kind of a constipation, and this is also an injectable drug that needs to be given. So there are certain issues like concerns also related to like any kind of an injectable whenever you use, so that might have certain kind of a skin reactions as well. So in your patients, like how did you manage this the nausea or like any kind of a GI disturbance or any kind of skin related issue? So how did you manage in your patients?
So when it comes to side effects or adverse effects of Saxenda, I will always I will always try to assess the severity of that adverse event. If the nausea and vomiting is present, and I will just ask them how many times have you vomited, or how bad is the nausea, and if they actually tell me that it is improving over time, I would just monitor. I will not give them additional medication. Those who have persistent nausea, I may actually supplement with some antiemetics. So like I said, vomiting, I only had one patient with vomiting. So even then, that was just a one-off occasion. So I have not I didn't need to treat that vomiting issue. Is usual. We have to again get a proper dietary assessment as to what is the cause of the constipation. And most of the time is when there is no drive to eat, there's also no drive to drink, and they tend to drink less, and therefore they became more constipated. But again, constipation can be easily treated even with things like lactulose, so it's no issue. With regards to the injectable site and the effects that you see from the injectable area, we will always educate them on the proper way of injecting Saxenda. I always tell them that there is two circles. There are two circles around the umbilicus. There's an inner circle and there's an outer circle. So it's always best to start from the outer circle in a clockwise manner. Do not inject the same site every day. Go around. Once you finish the full cycle of the outer circle, go for the inner circle. And once they've done that, a lot of my patients come back and tell me that they do have certain numbers. I will always tell them, I always refer to the clock. So there's always a certain time, maybe a 3 o'clock or a 7 o'clock position that produces more pain. Perhaps there are more nerves in that area. And I'll tell them to basically just skip to the next time. So instead of 3 o'clock, just skip straight to 4 and try to avoid that area. I do have patients who are on aspirin or anticoagulants, and they do develop some very mild hematoma. Now the needles are extremely small, they're really, really tiny. It's very unlikely to cause any significant bleeding unless it has actually hit a blood vessel. But subcutaneous blood vessels are not known to be large, unless you have portal hypertension. So in that region, in that sense, these adverse events are really quite minor.
Okay. Thanks, Dato, for enlightening us on this. So, next few questions are for Dr. Saiful, of course. So he will be there with us. Maybe since you are leaving, so I'd like to thank you from the Novo Nordisk side for being here with us on this Sunday morning, and then enlightening us with the Saxenda and all this, answering to all the questions. Thank you so much, Dato.
Thank you, Sid, and thanks Saiful for being the Hulk. Thank you.
I love your Instagram and your. Well done, mate.
All right. Thank you, everyone. Bye-bye.
Thanks. So, yeah, moving on to Dr. Saiful. So, we have received one question on that. This is on the question is like, how helpful is liraglutide in obese patients who have underlying hypothyroid? And what is the dose to start with? And is there any interaction with levothyroxine if it is the patient is already on the levothyroxine?
Okay, so answer to the second question first. There is no known interactions between L-thyroxine, whichever brand that may be either Oroxine or Euthyrox that we have in Malaysia. But usually what I tend to do is if I know that there is an underlying endocrinopathy, I would treat that. So let's say patients profoundly hypothyroid with a TSH of more than 10, 54, in the low range less than 7, and a high thyroid peroxidase antibody of more than 60, probably indicating primary hypothyroidism due to Hashimoto's thyroiditis, because there are other endocrinopathies associated with that. So I would probably start them on thyroxine, see the effect of the thyroxine, get them clinically euthyroid first and biochemically euthyroid. That will take you probably about 4 weeks. So by that time, you probably see some development in terms of reduction in weight as well. And of course, let's say the patient still got class 3 obesity, you know, BMI of 40, then you will probably start the patient on pharmacotherapy specifically for the weight per se. Usually the first couple of weeks before I jump onto pharmacotherapy for obesity, I always look at, as I mentioned earlier, any endocrinopathies, treat it first. Any medications that can interfere or cause weight gain, stop them or change them. The difficult part, if patients are on antipsychotics or antidepressants and they do need them, but I always try to change. And to me, the biggest learning point is if they're on olanzapine or mirtazapine, these are the ones that are associated with the most amount of weight gain. Some of my patients on quetiapine and risperidone, they also cause weight gain. Work very closely with psychiatrists to try and change that. Similarly, as a diabetologist, I make sure they're on things that doesn't need to weight gain, so metformin, SGLT2 inhibitor, DP4, GLP-1. Those are the things I would make sure they're on, not on sulfonylureas or insulin, try and reduce that risk. A lot of our patients that we also see are hypertensive. So there are certain blood pressure medications that can be associated with weight gain. Technically, the only one that I know of is a calcium channel blocker, like amlodipine, because you get this distal peripheral edema that leads to mild to moderate weight gain, mainly through to fluid retention. But there is some adiposity excess that can be associated with that. So look at the medications very carefully. Get rid of those if they have underlying hypothyroidism, Cushing's, treat that. And then if they still have significant weight gain, start treating with pharmacotherapy.
Yeah. Thanks, Dr. Saiful. So another very interesting question, because the fasting month is coming now. So the question is that if a patient has to be put on Saxenda, so is there any guideline that you would follow, or like any dosing, like when would you start the medication, and what will be your take on this?
Yeah, so the way that it works, the mechanism of action of liraglutide 3.0, which Dr. Saiful has explained earlier, it actually is beneficial during fasting month, because technically fasting month should be fasting month rather than a feasting month. So what you want to turn off is by the time the dusk sets in at iftar, you do not want that significant amount of, one would say, appetite stimulation. You actually want to reduce the hunger hormones that you would have accumulating by that time, and increase the satiety hormones per se. So the effect of liraglutide 3.0 milligrams would be very beneficial at that particular juncture. So to me, if the patient is already on or wishes to commence on this GLP-1 receptor agonist, I haven't had any issues during Ramadan per se. Now, saying that in the world of Muslims in the world, there's about 2.3 billion Muslims and about 160 million plus who are diabetics, and they want therapy to reduce the sugars, but also help to continue weight loss. To me, in that particular cohort, to reduce their weight gain risk, and I've had patients who've been able to lose 5 kilograms in Ramadan without any of these therapies, without GLP-1 receptor agonists, just by fasting by itself. If you have an element of another therapy that allows them to switch off their hunger and increase their satiety earlier, ergo you have a further weight loss on top of that, and reduce the amount of food that they eat, not just at iftar time, but what I call the moreh time, which is the nighttime eating at about 9:30 to 10 o'clock at night, when people want to have their little cakes after they've done their Tarawih prayers. Now that's the hard part, the nighttime eating. And I think there's a syndrome that's described with nighttime eating. If I recall correctly, there's a particular syndrome that's associated with this. I think it's called the night eating syndrome. It's described this guy called Skunkard, I think his name was, and where there's a group of patients that consume most of their daily energy intake at night, and these patients experience insomnia, and they got this morning anorexia. So they have this hyperphagia at night, especially in the evening time, but you want to reduce this amount of what I call the late night syndrome or late night eating per se, and having a GLP-1 receptor agonist like liraglutide on board will be able to reduce that intake per se, and patients are able to self-monitor their food intake more by taking this.
Okay, so like the timing, which one you would advise? So early morning or like in the evening time, which one would you advise more?
The problem about liraglutide per se, the mechanism of action, and it's, you could probably say anecdotally it's better to take it iftar time because maybe you probably need a lot less then. But the way that it lasts for 24 hours or more, it doesn't really matter whether you take it at sahur time in the morning or you take it at iftar time. Psychologically, you might think that probably better you take it at iftar time, but there's no sort of enlightening evidence that we have that one should take it at one time or the other as such. But psychologically, then you can take it at when you break your fast at iftar.
Thanks, Dr. Saiful. So, because with the liraglutide, it can be taken at any time of the day. So, yeah, thanks. So, I have another question here. So, it's the question is that if a patient misses a daily dose, should they extend the doses a week longer? For example, a patient is on 0.6 milligram for a week, and the patient misses 0.6 just one day. So while going to next week to 1.2, so whether they should be on 0.6 milligram for another week and then should escalate to 1.2, or like straight away, even if they missed one day, they can next week they can go to 1.2.
Yeah. So to me, the way the generic sort of step up in the dosing, if you've done even you don't even have to, let's say, complete the full 7 days of that. If you've got 6 days of the 7. And you don't have any of the severe nausea, vomiting, side effects, you can step up to the next phase. You don't need to do another week unless you have had some side effects along with it. So I think simplification is you miss a day, go on to the next one on Monday. So let's say you miss it on Sunday, Monday you start at 1.2.
Yeah. And also from the Saxenda recommendation is that suppose the patient is on the medication, suppose Monday, Tuesday, Wednesday, on Wednesday the patient missed one dose, didn't take, so no need to give 2 doses on the Thursday. So just go with the 0.6 on Thursday as usual and just continue. So you don't escalate to 2 doses like 2 shots of 0.6 on the Thursday. So that you can continue, like what Dr. Saiful just mentioned. Yeah. So another just quick question to Dr. Saiful, to you. So since we are talking about this weight loss here, so there are certain type of patients which might come to you and say that, I've been in this drug for like for last 1 month or like 1.5 months, and still my appetite is not so good, suppressed, and then I'm still able to eat. I'm not losing enough weight, and these kind of things they might say at sometimes. So how do you handle that? What are the things that you would like to look in the patient and try to explore more in the patients if they are saying something like this?
Yeah. So as I go back to, it's all back down to the 80% of history and examination. The history is really important so that you do not miss any other facets that's causing the hyperphagia or increasing appetite. Are there any other medical conditions that I mentioned earlier? Underactive thyroid, vitamin D deficiency, Cushing syndrome, growth hormone deficiency. That's why I really want my patients, if they can, like what Saiful said as well, take a picture of the food that they eat. Because a food diary is kind of really important to know. How are they self-monitoring their food intake, even for a brief period. It's really, really good to see any accurate records of that, because most patients tend to underreport it. So if they're saying that, okay, I'm still having the increased appetite, but do they have any evidence of that? What's the picture like of the food that they're taking? Sort of what we call close to real-time monitoring if possible. And I think that would be a good opportunity for both doctor-patient relationship to establish that trust, that we know, okay, this is what they're eating. Are they eating far less? Are they eating far more? And then if we know about that, then we can engage the dietitian specifically to enthuse the patient regarding how we can get significantly lower calorie intakes. I always tend to tell my patients we're aiming for 1,200 calories a day if possible. And are they able to get to that? And I think if you are able to maintain that, then you're able to maintain a significant amount of weight loss regardless. Because your energy output, depending on the weight, and there are multiple calculators that can do this, most patients would easily burn about 2,000 calories or more per day. That's just with minimal light activity, waking up in the morning, going to the toilet, having breakfast, going to work, coming back, 2,000 plus, easily. And if you're on 1,200 calories and you're able to maintain with a food diary showing that you're maintaining or consuming that much or that little daily energy intake, then you should be able to lose weight per se.
Okay, thanks, Dr. Saiful. So we have actually overstood the time, so it's the last question. So with this, I would like to now wrap up because it's already 12:20. So thank you, Dr. Saiful, for being here with us on Sunday morning. So as again, like I have intruded into your morning activity again on this day, but thanks again for coming here. So and sharing all the data and then all the tips about using Saxenda in the patient. So and thanks to all our audience for being such a wonderful interactive audience for today. So you have asked so many questions, you have unmuted and then also asked questions to our both the speakers. So thank you so much for being such a good and wonderful audience. I'd also like to thank the Novo Nordisk, our marketing team, as well as all the sales colleagues for inviting all the doctors here today, and marketing assistant also for helping me in this webinar. So with this, now I would like to thank and then would like to close the session now. So thank you so much and have a nice day. Okay, thank you, Dr. Saiful.
Thank you.
Thank you.